Matthias Götberg, Mike Gibson, talking about some analyses from SWEDEHEART looking at iFR versus FFR and long-term outcomes. Tell us what you found.
Thank you for having me. So obviously we have the background of instantaneous wave-free ratio or IFR that's been around for 10 years now. And that has been compared to previous trials against fractional forward reserve or FFR. And we know from validation trials that we have about an 85% agreement between the two indices. So I was PI for the iFR SWEDEHEART back in the days where we randomized between iFR and FFR and looked at the outcome. And we saw a similar outcome between iFR and FFR at 1 year. And then last year we presented the 5-year follow-up showing also a similar outcome between the two indices. Now we had a sister trial with defined flare. That was the global trial. And that also showed a similar outcome at 1 year. But this year at PCR, Javier Escanet showed the 5-year data, and that showed an increase in mortality, which was kind of a spurious thing because it surprised us all that it was an increase in mortality with IFR. And now the interesting part of this was not among the patients who were deferred from revascularization, but it was patients who actually were treated. And we could really see a difference in myocardial infarction or unplanned revascularization. So it's a very isolated increase in mortality. So what we did is that we went back to our registry. And living in Sweden, we have the obviously the great option of using our national quality registries and the fact that we have unique personal identifiers. So we could pick data from multiple different registry and then pool them. So we did analysis from our national registry, the SWEDEHEART registry, and found 42,887 patients that had undergone either IFR or FFR guided revascularization. And we were able to follow most of these patients up to 5 years, and we tracked the sort of death, cause of death, myocardial infarction, unplanned revascularization, both PCI and CABG for all of these patients.
And was there any difference, in who got IFR versus FFR? Were there any confounders that may have played a role here?
For sure, we could see that these patients obviously included between 2014 up to 2022. And so obviously some of these patients before we had the outcome data were used mainly among the older and the sicker patients. So we could see that the baseline demographics were not totally balanced. The iFR was more often utilized among women, patients who had diabetes, previous MI, previous stroke, and COPD. So we're not completely balanced these groups, but we can use multiple adjusted models to model for these differences. And this is really what we did.
Hmm. And what did you find?
Well, overall, one of the interesting things that we found was that there were differences between the deferred and the treated groups in terms of baseline characteristics. So it seems like the IFR and FFR provide slightly different answers in terms of deferral or revascularization, depending which index you're using. So we can see, for instance, in the treated IFR group, the patients were older, more women, diabetes, hypertension, MI, and stroke. Whereas we didn't really see the same thing among the deferred patients. So it seems like depending if you choose to use IFR and FFR, you get slightly different answers. In terms of outcome, though, after doing adjustment for these known confounders, we really didn't see any difference. So if you look at 5-year MACE, the adjusted hazard ratio was 0.99. This is really overlapping curves. So no difference at all in MACE. And obviously, you want to look at the individual components of MACE, the all-cause death, myocardial infarction, and revascularization. And we couldn't really see any difference at all in neither of these. And obviously, since the defined flare showed a difference in mortality among the treated patients, we did a secondary analysis and then divided the groups between deferred and treated, and also looked at MACE, death, MI, and revascularization. And we couldn't really see any signal at all. We completely neutral all across the board.
So what's the take-home message for practicing docs out there?
Well, the take-home message is that you can use either index to guide your revascularization, and I hope this puts the end to the discussion of pitting iFR versus FFR in terms of outcome. They're very similar. There's no difference at all in this very large all-comers real-world study.
Yeah, I think the bigger issue is not using physiologic testing than using IFR versus FFR. So, well, thanks for reorienting the discussion, Matthias. That was very helpful. Thanks for joining us.
Thank you.